Good evening. Why don't we get started? My name is Jim Greenblatt, founder and chief medical officer of the Psychiatry Redefined. And we're going to begin to share a little bit about integrative functional nutritional psychiatry and try to help sort through this question that we're being bombarded with. Our patients are asking about supplements, and they tend to be very knowledgeable between their AI buddies and their social media and their reading and what's available now. They have a lot of information and they are not only testing us, there's some real concerns and really good questions. So, this few months before the summer is when Psychiatry Defined um, provides a series of free webinars to share a little bit about our fellowship. Our general fellowship starts in July, pediatric end of July, where we provide a deep dive, a year-long program teaching clinicians how to understand, how to answer this question. So I don't want to frustrate. I saw some questions that came in before the webinar. What supplement should a 42-year-old woman take or a 32-year-old man with depression? That's when this is not going to be that. It's Psychiatry Defined. We have over 400 hours of content that's available. I would say 75% of it has to do with understanding how to use nutritional supplements. So I'm going to just turn my camera off for a little bit while I focus on the slides and try to help answer this question. And I'll leave time for questions. Again, sometimes when you see a topic like this, we try to answer a year's worth of programming in a few minutes. But if there are questions on the content, I'm going to start with the big picture and then focus on a few um, micronutrients after kind of defining the chaos in the field. So when I started talking about this stuff in the 1990s, I had absolutely no research to share with colleagues or the community at the time that diet has any bearing on mental health. I actually had, as a child psychiatrist talking about ADHD, I had to present negative studies that the pediatric community did, that sugar doesn't affect behavior and dyes did not affect behavior, even though it did for many kids. But now, 2022, 2023, 4, 5, 6, we have indisputable research about how diet affects behavior. These are every kind of study that's been done, looking at diet recall, dietary intake, looking at um, uh, groups from around the globe. So now we have research to support what your mother and your father and your grandfather and everyone's been trying to say for a long time, that diet affects behavior. And we can summarize the good news in that any of the healthier diets had some benefit for depression in particular. But the ultra processed foods, the refined sugars, have consistently been shown to have increased the higher incidence of the ultra processed foods in the diet, higher odds of depression, anxiety, risk of depression, and then there are suicide studies and cognitive decline studies looking at meta-analysis of millions of people. So in Psychiatry Defined and in anything that I talk about, we have to kind of rethink this term alternative medicine. we're talking about nutrition, we're talking about supplements, please don't use the term alternative medicine. Don't let our colleagues or our patients or anyone use this term any longer, because nutritional medicine, understanding supplements, understanding testing is just good mental health care. And, a little history to start. When we think of micronutrients affecting behavior, it's hard not to go back to the early 1900s. And I used to always start with this slide for 20 years, and each year I do it, less and less people have heard of pellagra. So I'll ask this group, how many people have heard of pellagra? It's a vitamin B3 deficiency. Oh, thank you. I got some hands being raised. I appreciate it. It is truly a remarkable time in our history, our mental health history, because it was a B3 deficiency, vitamin B3. We didn't know it at the time, but almost 2/3 of psychiatric hospitals in the South of the United States was filled with patients that had pellagra. They're mostly poor, mostly Black, and they were mostly eating very, very simple corn meals, usually 3 times a day or whenever they ate. And that created a profound deficiency of vitamin B3. And one of the symptoms of vitamin B3 deficiency is pellagra and skin rashes, but there's a depression and a psychosis. So those individuals in the early 1900s in these psychiatric hospitals, you and I could not tell the difference between what you and I would describe as schizophrenia and what was not diagnosed at the time, but was seen as pellagra. So it took a few years, but a public health doctor, Joseph Goldberger, didn't know what it was. Everyone thought it was an infection, but when they put brewer's yeast, we're talking about tablespoons of brewer's yeast on their food, people walked out of the psychiatric hospital. Their psychosis was eliminated. Okay, it's a pretty remarkable story because it's billed in our history books. We literally emptied out psychiatric hospitals by putting brewer's yeast on the food, repleted the B3 deficiency, the depression and the psychosis lifted from many, and that is the history of pellagra. Eventually, it took a few years before they figured out it was vitamin B3 in the brewer's yeast. But the punchline, the reason I'm starting here, and it's just helping you and your patients and your colleagues appreciate that one vitamin deficiency, vitamin B3, causes a major mental illness. Now, we don't call it schizophrenia because we can treat it and they walk out the door fine, but pellagra looks like schizophrenia. And in my career as an eating disorder doctor, I've seen pellagra. There's cases of pellagra, alcoholism, anorexia, and they are psychotic. You provide B3 and it lives. So in my career, I got involved in this nutrition and brain function in college. Well, actually, even before college, in high school, I was reading about it. But I started writing papers and taking classes in college, often having to develop my own classes, private programs. And it just became remarkable, the history that I was reading. And I couldn't understand, and that was 40 years ago. And I still can't understand why nutritional therapies are so hard to get incorporated in our medical model and certainly our mental health model. I found this article in JAMA in 1984, written by two physicians, Goodwin and Goodwin. Um, I don't think they were related, actually. But anyways, most prestigious journal at the time, the tomato effect, and and they just wrote about why highly efficacious therapies, particularly nutritional interventions, are rejected by medical colleagues. And they used a number of examples. And in Psychiatry Redefined, we might have hundreds new examples. But the tomato effect was named because from 1600 and something, whenever we came over here and settled from England, until 1864, we wouldn't eat tomatoes in this country. Why? Because they were poisonous, right? They were part of the nightshade family. So even though for those 200 years, people kept coming back and forth from Europe, and tomatoes were a big hit, right? They had pizza and having a good time. But it took 200 plus years before someone stood up in the Times Square of Salem, New Jersey, ate a basket full of tomatoes and didn't die, didn't get sick. And that changed certainly the use of tomatoes. But it's just a powerful image for me because I'm going to share with you a little bit about nutrition tonight. I'm going to talk about amino acids and some B vitamins and vitamin D and the trace mineral lithium. But there are many, many nutritional interventions that have major impacts on medical and our mental health populations that are completely ignored, often rejected. Things are getting better. So I use this slide for some of you clinicians that are trying to sort through, I'm doing a lot of psychopharm. I know there's a better way. I give my kids supplements. I take supplements, but what should I give my patients? And you go to a conference, it gets exciting, and you go home, it gets a little overwhelming. What's the interaction with the medicine? What was the dose they mentioned? And then you might get stuck on one supplement or one test. It's challenging. But I also use this image for so many of our patients. So many of our patients who have not gotten the results that they expected, that we would expect in any other medical specialty when we have an expertise. The meds don't work enough. There are side effects. You're adding the second and the third medicine. They can't get off the medicine. You know the list. We're not going to pick on medications. It's part of our treatment. But I think clinicians are struggling with how to use integrative and functional medicine, and our patients are really struggling as well because they're just getting the information of social media. So this is why I keep doing what I do. It's just pretty remarkable. This was a 2023 paper the CDC wrote up. 17% of these teens reported depression in the past 2 weeks. But the statistic that kind of makes me shiver, working in inpatient adolescent units, is the last one. 20% reported seriously considering attempting suicide. Now, that's not the 40% thinking of feeling sad and hopeless. That's the kids we see about and hear about and talk about and try to do a better job with. But 20% of our high school students thought seriously of taking their lives in the past year in 2023. So something's going on. And there's nobody that can deny that our polypharmacy approach is just educated guesses. It's fast food, in and out visits, and this is not mental health treatment. And then this I left in, I saw it over the holidays. This is also, I don't think, mental health treatment. This was in Brooklyn, I think in a few blocks, I saw 3 or 4 ketamine clinics. But it was a big ad. You can get your holiday boost, 25% off. I don't think this is mental health treatment as well. So quickly, you're all familiar why the reason we got into this mess in mental health treatment. Why are so many patients are struggling? And I think it's simply the model. In every other branch of medicine, we have symptoms that get assessed with objective tests, right? This guy has a sore throat. Is it strep? Is it COVID? Is it pneumonia? Is it tongue cancer? I mean, there's something that we're going to look at, we're going to culture, and then based on what we find, we're going to give a medication or a treatment. Could be surgery, could be medicine, it could be any form of therapy. And then we're going to test it again and think of knee pain or chest pain or ear pain or that violent headache. You don't know if it's a brain tumor or a migraine. But we do testing, and that objective test dictates treatment. And in psychiatry, we just ask a lot of questions, and it doesn't make it any better that they're computerized now. We're still asking questions based on symptoms, giving medicines based on symptoms, and then the sad reality, follow-ups are months and months away. To me, that's not adequate mental health treatment. There's no concept of underlying etiology, right? No testing, no physical exam, no objective test to prescribe that antidepressant or antipsychotic. And I'm going to challenge you at the end and use the word, what is our ethical obligations? Okay. The APA has this 100-page guideline of ethics, and one is to be aware of the medical needs of our patients. Okay, so that's the model. And what I'm trying to share in Psychiatry Redefined with our at least 40 faculty, we have clinicians from all over the globe now, 17 countries, is that maybe we stop focusing on this epidemic and how many people are taking medicine or how many people are struggling, and think about the model, the mental health care, the symptomatic based model, which ultimately only leads to polypharmacy, is not sufficient. And everyone knows that. Every depression article, I love reading the beginning of every article because they have this new thing they're trying to show, but they all start with the same thing, that 1/3 don't get better, and we still don't have a adequate treatment model. But I think we do. And Psychiatry Redefined is based on helping clinicians look at integrative, functional, nutritional, and metabolic psychiatry. Now that's a mouthful. It's a lot, but everyone's got their own camps. When I used to give a talk, I had to put integrative and functional and nutritional on the same slide because everyone was attached to a different thing. Now, we, over the last couple of years, have just understood the work that we're trying to teach clinicians is functional psychiatry, right? And what is functional psychiatry? It's just adding more tools to your toolbox. It's not removing medications. It's not removing lifestyle medicine. And it's not removing the role of psychotherapy. It's just saying, what are the genetic vulnerabilities? What are the current nutritional state of that individual? What are the hormones? What is the gut microbiome look like? What is going on? Can we find some biochemical, genetic vulnerabilities, root cause medicine? It doesn't usually end up with one magic hat that picks one nutritional deficiency. It's multiple things, but they all add to our patients. So look at this for a minute. We've all been there, right? And our patients, I've been talking to a lot of patients. We opened this new clinic and I'm talking to patients, and everyone tells me the same thing, that their doctors and nurse practitioners keep using the term, we're going to try this. We're going to try the next one. We're going to try. That is coming from a medical professional. And so our treatment, whether it's OCD, depression, and certainly some of the more challenging illnesses like schizophrenia, it's pretty much all over the place. Someone might get better, they might get worse, they might have side effects. We're going to have the second medicine, but this is kind of what it looks like. But I'm pretty confident that functional psychiatry, integrated nutritional medicine, genetics into your treatment plan. When you first see the patient and do the objective tests, you're going to have a treatment plan. Now, you're not going to give your patient 10 supplements or 12 medicines at the same time, but you're going to know when these tests come back that they have a genetic defect of MTHFR. They might need folate. They have a high homocysteine. They might need B12. They have a vitamin D of 10. So you're going to know all that objective data while you're continuing your empathic therapeutic alliance as a mental health clinician, and then using that objective data to decide therapy, medications, or any other form of therapy. So think about it. We've all been there. It's pretty much the day in the life of an inpatient, outpatient psychiatrist. This is closer to a day, or I should say a month in the life of a functional psychiatrist. So things are getting a lot better, right? The research is just overwhelmingly supporting everything we've been saying for 30 years. So ketogenic diets are now hot topics and being done at research institutes around the country. Lifestyle medicine is now fellowships. Nutritional psychiatry is has conferences. On the Psychopharm conference at Harvard, they added on a nutritional psych component. This is going mainstream. Life is better for some of us who've been pound on pavement for a long time. But this gets a little disappointing. There's a group of clinicians who are organizing the next DSM, right? It's APA subcommittees. How can we make the APA, the DSM better? And they're talking about more holistic, more comprehensive, but this is just overwhelmingly kind of frustrating to me. They say biomarkers reliable tests, and it could help tremendously, but the next DSM, which will be years from now, will not have any biomarkers for immediate use, but a series of candidates clinicians should watch, which infuriates me because many of us have been talking about biomarkers. Particularly, I encourage anyone to look at our suicide prevention course, where we discuss 8 or 10 biomarkers proven to increase risk of suicide that nobody's doing. So it's a little frustrating because I believe, and I've been talking about and teaching biomarkers as roadmaps to treatment for 30 years. And the DSM subcommittee is saying we're not ready for it. And if you're into medical school or nursing school or any other graduate school, you learned a lot of stuff like what might be contributing symptoms for depression, right? If you had a multiple choice test, you'd have to say what iron deficiency, anemia, B12, copper deficiency, hypothyroidism, low testosterone, trauma, heavy metals. lead, mercury. I mean, the list is endless. And these are all things we were taught in school. And then we get out in clinical practice. And I don't know, how many of you are checking iron on a 28-year-old male? How many of you are looking at hypothyroidism before you start antidepressants, testosterone, vitamin B12, vitamin D, vitamin B1? I mean, the list is endless. But we know it, but there's no clinical application. And, I just use this as an example of, and I'll change it to men next time, but 5 women, let's call them 32 years of age, that present with the identical symptoms that we diagnose as depression, right? They're not sleeping, they're doing poorly at work, they're feeling more hopeless, helpless, they're sad, fleeting thoughts of suicide, not motivated. Each one, if they went to psychopharmacologist A, would get a prescription, let's say an SSRI. But if they went to 5 different, they'd probably get 5 different SSRIs or antidepressants. So nobody can tell me that's medical science. That's educated guessing. They all might be helpful. They all might have side effects, but no objective testing. But what if we looked at this as a functional psychiatry patient and looked at screening labs for amino acids and fatty acids and iron and thyroid and heavy metals? So Debbie might have iron deficiency anemia unchecked and not treated. Deb might have low thyroid. Deborah might have a B12 of 220, which someone told her was normal. Debbie might have a history of trauma that never been addressed. And Deb's might have very high mercury that was never looked at. And we could go on, but there are lots of contributing factors to depression. And how do you know unless you test? So for those of you that are new to this world, I just wanted to clarify, I use the term functional psychiatry because I like to integrate nutritional, psych, genetics, functional, and integrated medicine. But many of you are familiar with integrated medicine, or because there are fellowships now in lifestyle medicine, and medical schools are not only teaching cooking to doctors, but they have mindfulness programs and spirituality. So that's accepted, right? Our major academic centers. But functional medicine digs deeper. Functional medicine looks at genetic vulnerabilities. How do you metabolize vitamin D or folate? It looks at nutritional deficiencies. It looks at the gut, looks at fatty acids and amino acids. And a personalized medicine path integrates these two areas. So a couple examples. Larry kind of became a professional patient after barely finishing college. He's very bright, very wealthy family, went to doctors around the country to try to find help for his depression. He could never come off his medication. Multiple trials, these are just some of them, and a very strong family history of addiction, ADHD, and depression. So Larry looked at, all these diets, and he ate the perfect, health food, organic diet. And these were some of the supplements. Okay. And I mean some of the supplements that he came in on when I saw him. And couldn't fit them all on one page. Because he went to Dr. A, who gave him a few supplements. He read about an article and then he added a few supplements. He went to Dr. B, another part of the country. He was desperately trying to get help. And they were just throwing supplements at him as he had previously had medications thrown at him. So we did a a routine battery, and one test is not, people aren't as familiar with. My red doodles there are is amino acid levels. So they should be to the right of that white patch, and that is where those are normal. Okay, 50th percentile is white. So Larry had everything low. So he had low levels of amino acids. Now, what does that mean? It means even though he was eating steak and chicken and organic eggs and all these expensive foods, he wasn't breaking down his protein, which means these amino acids are building blocks of every protein in the human body, particularly the neurotransmitters, serotonin, dopamine, norepinephrine. So Larry was just given these free-form amino acids, digestive enzymes, so he could break down the expensive protein. And Larry got better. His mood improved very quickly. And then within months, we were able to help him get off these medications. But think about it. And this is an hour lecture on digestion and zinc and how the lack of digestion affects protein. But by testing, we could see it. So we gave him amino acids. We gave him digestive enzymes. And Larry, who I'm still in touch with, continues to do well. So again, I'm not going to do 400 hours of content, but I wanted to share a few other things. So amino acids is one test. And the B vitamins, again, is complicated. But I think if there is kind of one class of vitamins that you should kind of look at and try to understand, it would be the B vitamins for brain health. Each one, we'll talk a little bit about B12, folate, B6, B3, niacin, thiamine, riboflavin. They're all critical for mental health. So I'm going to go back to my obsession with biomarkers and the DSM telling us in the next round that we're not ready for biomarkers. But how about if we go to 202, New England Journal of Medicine, most prestigious medical journal in the country, published an article about this marker called homocysteine as a risk factor for dementia. Increased plasma homocysteine, a strong independent risk factor for the development of dementia and Alzheimer's disease. You don't get more clear and you don't get a more rigorous review than the New England Journal of Medicine. What do we do? Nothing. Absolutely nothing. So 16 years later, we try again. This is a Journal of Alzheimer's Disease. This was an international group of experts, looked at the 20 years of literature. And guess what? Homocysteine, a modifiable risk factor for cognitive decline, dementia, and Alzheimer's disease. Now, we're not going to talk about dementia, but it's also a risk factor for depression. But just the fact that we have these dramatically well-done studies telling us we have a biomarker that predicts dementia and what I'm sharing with you, depression. Elevated homocysteine is a metabolism gone awry. It is a deficiency of B vitamins. It is that simple. I'm just going to repeat it because you can help a lot of patients by just, one, testing for homocysteine for every psychiatric patient and understanding the treatment is simply folate, B6, and B12. Neural tube defects, heart disease, Alzheimer's, mild cognitive impairment, schizophrenia, depression, Parkinson. This is not Psychiatry Redefined making this up. This is extensive research over 30 years. And again, the dementia is what I started with, but we have associations with depression, right? This is a blood test that costs very little, that can be done on every patient. So these individuals followed for a number of years, and high homocysteine, depression. High homocysteine in these kids, anxiety. And then let's just take it up to 2025. Okay, new research, elderly patients, okay, age matched, double blind, placebo controlled trial, elevated homocysteine associated with depression and cognition. Okay, so homocysteine is something that if you're not familiar with, you should be. It's simple. And the treatment are those B vitamins. We're not going to have time to talk about all of them, but I am going to talk about what I have said many times is one of the greatest tragedies in all of medicine, and B12. So B12 deficiency is one of the reasons homocysteine gets elevated. B12 deficiency is common, but B12 deficiency is also missed, tragically missed by psychiatrists who usually don't even test for it, and even PCPs who don't appreciate this concept here. This normal versus optimal. Many labs in the United States define B12 as this one under 148. Some are under 100, and let's just say 200. Okay. And most people have higher levels. And for years, we were saying treat everyone under 500. But now this study that came out in 2025 actually did that. They were able to do this research study and say the normals, which is under 200, is not optimal brain function, and that there's cognitive decline under this 500. They came up with 414 for 30 years. Myself and the integrative community has been talking about you have to treat vitamin B12 as a deficiency if a level is under 500. Okay. And this study looked at it carefully and came up with the norms are not optimal. And with what's considered normal, you can develop cognitive decline. In my practice for years, we're treating patients who were told that their B12 was normal because they had 200 or 220 or 300. And the PCP looked at it and it didn't have a big L next to the lab. So it was normal. But they struggled. And we gave them a couple B12 shots and their depression lifted. Yes, in the world of functional medicine, there are times you can use words like remission and cure if you find the underlying cause. And with B12, it's not that challenging. So we look at B12 levels, we look at homocysteine levels, and methylmalonic acid is something we learn in medical school that B12 can only be low if methylmalonic acid is elevated. And I can just tell you, and I cannot tell you the mechanism, but it's absolutely false. I've had hundreds of patients that had normal or low methylmalonic acid and low B12. And with supplementation, their symptoms improved. So we can look at methylmalonic acid at blood or urine, look at a B12 level, treat anyone under 500, and definitely look at homocysteine. If somebody is deficient in B12 and they're eating meat, they're either have an absorption problem, low acid, or pernicious anemia, an autoimmune to intrinsic factor. So you don't want to give them B12 pills, capsules, or liquids. I see all these B12 liquids. You want to make sure it is a sublingual supplement. There's methylcobalamin, hydroxy, and adenoscobalamine for injections. I use hydroxy. For sublingual, I use methylcobalamin. It's usually about 2,000 to 5,000 micrograms a day. And again, injections can result in rapid improvement. These can be IM or even sub-Q. Often we try to do it 3 times a week for a couple of weeks and then cut back. And we didn't have time to go through thiamine and B3. Well, we did a little with pellagra. Thiamine is related to depression and POTS. B6 is related to depression and anxiety. B2 is related to supporting folate, and folate is related to every major psychiatric illness. But I did want to say is that a B complex supplement can often be sufficient for psychiatric patients, but it is not sufficient to replete B12 or somebody with MTHFR variant that needs L-methylfolate. So that's a quick B vitamin story. The vitamin D story should be even quicker, but I think it's more dramatic. I think that the public health implications of low vitamin D are profound in terms of dementia, depression, and anxiety, and most significantly, suicide risk. If we flip this around, we can say 70% of Americans are deficient. The numbers globally are probably even higher. Deficient in vitamin D. And vitamin D, which many of you did not learn, is critical for serotonin synthesis. Vitamin D is the cofactor in this rate-limiting step in the synthesis of serotonin. So this vitamin D is critical for the activation of this tryptophan hydroxylase enzyme. Low vitamin D, guess what? Poor enzyme function, low 5-HTP, low serotonin. I mean, it is that simple. Bruce Ames was one of the first to demonstrate this. And what happens with low serotonin? Well, that's going to depend on genetics and environment, a whole bunch of things. Could be OCD, depression, anxiety, or suicide risk. But this is what happens. So when you see these kids, these adults, it's vitamin D deficiency is much more common in people that are inside, darker skin. These numbers of 10 and 12 have profound implications. And again, the research goes way back, and Alzheimer's, depression, anxiety, and suicide. And this is a 2025 paper, a meta-analysis, 500,000 individuals, vitamin D levels in patients with suicidal behaviors much lower. This is one of 20 patients. These are younger individuals, almost 50% suffering from vitamin D deficiency, and here they looked at magnesium as well. Okay, and the problem that I wanted to just highlight a bit is that you're going to see the headline that vitamin D doesn't work for any disorder, A, B, or C. But let's just say a study comes out, does not help depression. Because these studies all provide very low dose vitamin D to everybody in the study, and there's no testing. And vitamin D is not going to help your depression, not going to help prevent suicide if you have a normal level. So, and that's never part of these tests. It's certainly not part of those headlines. So low vitamin D is a factor for some individuals and dramatic health benefits. Now, when you're repleting vitamin D, it's not by itself a significant quick improvement. When I think of vitamin D repletion, I think of foundation, filling in the holes of the foundation, and then other micronutrients work, medication works better, therapy works better, but without adequate synthesis of serotonin, we understand how dysfunctional the brain can be. And again, vitamin D, the rate limiting step. Okay, so we're going to end chatting about another essential micronutrient, lithium. In Psychiatry Redefined, we probably have hundreds, no, not hundreds of hours. That's exaggerating. We have courses, we have intensives, we have a 2-day symposium. I have books. We have a lot of content of microdosing lithium. And the summary, if you're not familiar with it, is lithium is in the periodic table, right? 6.94 is the periodic weight. And we have this medication called lithium carbonate, which is helpful for bipolar disorder. The element is used in technology, from airplanes to cell phones to fireworks to our batteries in our computers. And in nutritional medicine and integrative medicine, we use lithium orotate as a nutrient. And lithium, again, is a natural element, goes back billions of years when the Earth was formed, 4.5 billion years ago. It's in the rocks, it gets leached into the water and the food supply, but much of it is in the water, very little in the food supply. And I just use this, even though many of you aren't treating Alzheimer's disease, but this kind of supported our work, talking about lithium orotate for 30 years. But this was the paper in Nature in August, done a number of year study done by the Harvard group. So it's open access. I urge everyone to find it and read it. But it was just a pretty stunning, amazing paper that did get some headlines. And let me give you the punchline. So first of all, looking at, I think, 50 different elements in the brains of those that died of Alzheimer's compared to normals or mild cognitive impairment, lithium was reduced in the brains of people with Alzheimer's or mild cognitive impairment. No other element was. So lithium deficiency in the brain of Alzheimer's established. Okay. Number two, they have these mice models genetically bred to develop Alzheimer's pathology, plaques and tangles at a very early age. So that's how they study drugs. And so what they were able to demonstrate is that a low lithium diet, accelerated the onset of the plaques and tangles in these mice. Then they were able to demonstrate that lithium orotate in the diet, not lithium carbonate, lithium orotate, the nutritional supplement that we teach and use Psychiatry Redefined, actually prevented the pathology of the plaques and tangles. They put lithium orotate in the diet, prevented plaques and tangles. And then the most dramatic was lithium orotate actually reversed the Alzheimer's pathology. They gave him lithium orotate when they had the plaques and tangles. They watched lithium orotate get into the plaques and tangles, break it up, see the products in the urine, and the improvement in cognition in these poor mice. They tried other kinds of lithium carbonate in particular, did not do it. So many of our colleagues in psychiatry talked about lithium orotate as not only dangerous, but not effective. This kind of stopped them in their tracks. And now there are lots of people running around trying to do research on lithium orotate. Some of it is pretty misguided. We've been looking at this for 30 years. But lithium as a mineral has profound effects on prevention of Alzheimer's. And even more dramatic and more extensive is the research is lithium in the drinking water prevents suicide. This is not one study or two studies. These are many studies, hundreds of studies. It's a meta-analysis over 3 million people. We've known this for a number of years. The first studies came out in the 80s and done all over the world. Communities with low lithium in the drinking water, higher rates of suicide. Okay? And we know prescription lithium is anti-suicidal. And now we have very tiny doses of lithium in the water, micrograms per liter, anti-suicidal. So I just want to end on kind of my world of where I use lithium every day, and absolutely to prevent suicide. But what we're seeing in our practices, and I know you are as well, is the irritability, the mood swings, the impulsivity. And that's a core part of all of our practices, even though if we don't use those names, because think about it. So irritability is what you'll learn in Psychiatry Redefined is the symptom of a lithium deficiency, as well as impulsivity and mood instability. And look at all the disorders where irritability is seen. Okay, now in the DSM, we only mention irritability, I think a couple times, borderline personality and just DMDD, but it's part of bipolar 2, depression, autism. We have a drug approved for the irritability associated with autism, Risperdal, right? An antipsychotic approved for the irritability associated with autism. So that's what we talk about, functional lithium deficiency. We think of irritability, we think of impulsivity. And I put this here because I want people to appreciate that the lower doses, we're recommending the 2 milligrams. People are, now that lithium is kind of in and people are making lithium water again and high dose supplements. I've seen 20 and 120. Lithium, just like every other mineral, can have side effects at high doses. So physiological doses are closer to 1 or 2, and that's what we're looking at for prevention. We do use higher dosage for treatment. So I'm going to end quickly on the simplest path to malnutrition in our society, besides anorexia nervosa, is having celiac disease, right? It's a gluten intolerance, an autoimmune disorder, and you get this deficiency of major nutrients, vitamins, minerals, amino acids, right? Because gluten destroys the intestinal villi. And that malnutrition has been demonstrated for 20 plus years to be associated with mental illness. I use celiac and bariatric surgery as the powerful example of how malnutrition affects mental illness. So here, celiac associated with depression, anxiety, dysthymia. 85% of celiac patients, anxiety, 82 depression. Kids, high risk of any psychiatric disorder. So any path to malnutrition is going to result with brain function suffering. And the degree of that suffering is likely genetic, and the outcomes are going to be determined by a number of factors. But Psychiatry Redefined is set up to help individuals learn how to integrate functional medicine into their practice. Yes, some of it is simple, like testing for homocysteine, testing for magnesium. Some of it is a little more complicated, like looking at organic acids and genetic tests and hormones. But that's our path to having an objective test to help our patients. And you've seen this. We're going from educated guessing to this. In functional psychiatry, we're keeping our prescription pad. We're appreciating the role of medications. We're just adding tools to the toolbox. So I've been doing this a long time. I've ran inpatient units. I've seen very sick patients from around the country, international patients, and I know that our model is good, but not good enough. And functional psychiatry can create a really dramatic dent in these poor outcomes. So I know we can do better, and I'm hoping that you will join us on this journey and just taking what you've learned and just adding more. And that's what we want to improve our outcomes. Psychiatry Defined, we've trained thousands of doctors from around the globe. We have faculty over 30. We have experts in ketogenic diets, experts in psychedelics, experts in hormones, experts in trauma, experts in sleep medicine. We have a great team of faculty really committed to help. And then, in addition to the lectures and the supervisions, we have open office hours monthlies to present cases. But we also have a community that is daily interacting with each other, asking questions, sharing cases, as well as with the faculty. So join us. We have we've been through some of these, but we still have the ADHD training and antidepressant withdrawal coming up. So if you're in the fellowship, you get these what we call intensives for free. This is my life, in addition to Psychiatry Defined, my new book on depression, functional model for depression, finally hopeful, is out. And then The Lithium Revolution, it's my new book on lithium, will be available in a few weeks. And this is an outpatient practice where we're both utilizing doctors trained at Psychiatry Defined and helping patients who are licensed throughout the United States to look at a functional medicine model. That's finally living now. And we have educational consultants available, people that know the program, the fellowship, the general versus the pediatric, the intensives. It's an opportunity, a real unique opportunity. I think most people have been incredibly happy. If they're not happy with one course, they appreciate the community and they appreciate the working together to improve outcomes. The research has supported everything that we've been trying to say, and that just makes our job so much easier. So I apologize, I went a little longer. Let's see. Calcium supplements. Um, Depending if you're eating dairy, I'm not a huge fan of calcium supplements because magnesium is what is most significantly missed, and it's probably in mental health, and too much calcium can displace it. So if you don't have any dairy or other source of calcium, perhaps, but not if you're having a good source of dairy. We screen for probably 250 biomarkers. Someone asked what tests we screen for, so it's a little hard to go through quickly. We don't treat bioidentical hormone in the fellowship. We do have intensives of looking at hormone precursors in the Dutch test and how to utilize hormones, but it is part of the intensive. We do a couple tests. We look at either Intellex DNA or Genomind. So MTHFR is an important test that I think should be done on every psychiatric patient, but it's not the only test. Someone with mania is sometimes we get no abnormalities. Sometimes we do. So the testing is critical. But I also think there's many paths towards treating bipolar. We have a unique course. For ADHD, I do food sensitivities in kids. I don't always do them in adults. Withdrawal. Antidepressant withdrawal is an intensive we're doing. I urge you to look into it. I have a book on antidepressant withdrawal. It's all over the news, actually. It was a New York Times article this weekend about how psychiatrists are now looking into withdrawal or accepting the fact that they need to withdraw, help people withdraw. We've ignored it for 30 years. Psychiatry Redefined, we've had a course for 10 years. And this hyperbolic slow tapering is great. 20 years too late, but that's a great concept. But it's not sufficient. Functional psychiatry is a simple path of almost completely eliminating withdrawal symptoms from SSRIs in particular. So we're going to need to stop. There's no blood test for lithium. We look at a hair test. The only blood test we have is what is considered for pharmaceuticals. So I thank everybody again. Please reach out, set up an appointment, talk to Cindy or Layla, ask about what program. Um, and I really appreciate you taking some time on a Sunday to listen to me rant and rave about how we can improve our model. And I'm just looking for colleagues to support this mission. Thank you. Have a great night.